With that motivating set of remarks, we're now going to hear from the Planning Committee, whose spokesperson is logically the chairperson, the extraordinary, as we mentioned earlier, Peter Long, who is the president of the Blue Shield of California Foundation and the chairperson of the Planning Committee. Peter.
Good afternoon, everyone. It's great to be here. And thank you for the input, Jamia. I think you've captured the charge of the Planning Committee in your presentation succinctly. As I was listening to you, our challenge is to make sure that the 12 million people in America who have various conditions like Mrs. Smith have their needs met in a humane, affordable, sustainable way that doesn't require heroic, yes, I love your rock star, hello rock star workers. We're impressed by those, but the challenge is to have that individual experience be replicated for 12 million diverse Americans who also have high needs that may be diabetes or stroke, or it may be depression or substance use. It may be a variety of things, and that we have a system, as you said, we have shifted the norm. And the second challenge that you raised for us is, how do we take the elements of an amazing program like City Health Works in New York, or Camden Coalition, or PACE, or other programs, and have those become the standard of care, not the ones who we hold up and saying, wow, this is the positive exception or positive deviance. And then our third, if that weren't enough, our third challenge that you've identified is, and I think the question here, how do we make that financially sustainable, and how do we build that into the system? Whereas I am a philanthropist and philanthropic dollars are lovely, how do we make that the policy framework that it actually enables that? So I think you've done an amazing job in your presentation of highlighting the challenge that was set out at the beginning of our work. The other, just framing context, and then I will go through the slides. First is, this is very deliberate. We talked about, our title is Effective Care for High Needs Patients. So there's a lot of conversation in Washington about health policy and who will be affected. This population, by definition, has high needs. This is not theoretical. This is not that they may or may not be affected or need health care. These individuals, by definition, are folks who actually have high needs, not just in the medical care system, but also behavioral and social needs. And I think it's very important that that's the context, looking at that subset of the population who do have high healthcare needs. And then the last I'll say is that, to quote Gutta, who's on if you read any National Academy of Medicine publication, is an apt charge for us that we took very seriously as a committee. Knowing is not enough, we must apply. Willing is not enough, we must do. So our litmus test at the end of the day, and I think you'll be the judges here, those who are watching and those who read this report, is, have we given you direction and opportunities, motivation and inspiration to do? And to do things fundamentally differently for these high-need population than we do today, so that we all look more like City Health Works and that everyone is receiving the type of care and trust that Mrs. Smith is. So let me give you some highlights. And then the last thing I would say is the opportunities for improving outcomes, value, and health is also, we set an incredibly high bar for ourselves, and thanks to the Peterson Center for Healthcare, that we're not just saving money by moving folks or saving money by paying less. We truly are looking to improve outcomes within the system to produce something of value, meaning that it could be either a better outcome for the same expenditures, or the same outcome for less expenses, and that ultimately the health of the population improved. So it's kind of a variation on the triple aim, and that was the standard that we set for ourselves in this work. You heard this already, and I think it just is worth repeating, that a small percentage of the population generate a very large percentage of our healthcare cost. So the top 1% account for nearly a quarter of all health spending, and the top 5% account for 50%. But as Jose Figueroa and Ashish Jha will tell you, and Melinda, it's not the same people each time. It's not a constant or static group. And it is not a homogeneous group of folks who are generating these expenditures. So it is incredibly diverse. Although we can name it as 5% in one year or name it as 1%, That population actually changes over time and is very diverse within that subset of our fellow citizens. So just to recap on this project, and I actually think this is what to me made it exciting, and I think hopefully made these results will be applicable to many of you in the room and many of those who are watching, that this is truly a collaboration between multiple entities. And I think the National Academy of Medicine, what they do incredibly well, and we were incredibly fortunate to have their leadership, is they bring together and convene the brightest minds in the country. And at our workshop, it was incredible to see the care models who came, the policymakers, the patients who are experiencing these conditions all came and gave us their best thinking. And I think that's the leadership of NAM and their ability to convene and bring us together and also hold us to the highest standards of producing outcomes. And the Peterson Center is all about action. If you know Jeff and Emily and others, the Peterson Center has held us to, well, what's going to happen and what are people going to do with your report? How are they going to use these recommendations and keep it going forward? Harvard, brilliant minds at Harvard about doing the empirical analysis. And I think you'll see in the chapter of this report some of the segmentation work. What was fascinating to me at the beginning of this process is that we have not segmented the population for public policy in this way, using empirical data. If you actually think about much of our health policy in this country, we segment folks based on their annual income, their employment status, and their age. We don't think about what services they're using and their needs and derive our public policy around what their healthcare needs are, how they utilize services, and how we could actually match those services to those needs. And so I think that was a fundamental contribution from our folks at Harvard to deconstruct and to help us set up what I'll show you in terms of our segmentation. And then also the Bipartisan Policy Center to look for opportunities within federal policy today that we could align with practices and models that actually improve the care for high needs patients. And then finally, the Commonwealth Fund. It's been a pleasure working with Melinda, who, if you see the workshop proceedings, Melinda, I think, presented at every workshop. And whenever we had something difficult to present, we said, Melinda, could you please present it for us? And so she did a great job at Commonwealth. And if you see a lot of the citations in the report come from Commonwealth-funded progress as well. So I think it was a great partnership. And just to summarize, what we were trying to do was we really are driving towards better health outcomes. And it's looking at the characteristics of the patients, matching it to the care models, and then putting together a policy framework that actually supports those things. And so that's the way we approach the task. And you'll see from our recommendations, that's how we did it. I just want to recognize some of the committee members are here, the planning committee members are here, and some are not. It was a mixture of government folks, academics, practitioners, and policymakers outside of government. And what I would say, just commending them, is they remain committed, open, and curious. Sometimes you come into a planning committee and there's a preordained result, or they're looking for solutions that they've already done. This group, I think we were very open to following, and you'll see from forming 2 work groups and subgroups and taking the issues where they followed, where they led us, was just a testament to these folks, and they really did put in the time to plan the workshops, but then to also think about what the real-world applications were. So thank you to all the planning committee. So we held 3 workshops, and we were looking at 3 different topics. First was to explore who were the high needs patients, because we often do. I think everyone in this room, probably raise your hand, have heard the statistics about a small percentage of the population uses the bulk of the services. But really understanding what's beneath that, the heterogeneity, the diversity, and the dynamism of that population is critical if you're going to design care models and public policy to support them. So the first sense was truly to deeply understand this high needs population, and then also to begin the journey of what is successful care. And so I will say I am an optimist at heart. And while we could cite many, many studies of care models that are probably not showing the results that we want, I believe that we are at an inflection point. I think the committee agrees that there are enough care models out there where we have shown evidence where it's time to implement those at scale and to drive those further. Obviously, as a health services researcher, we could research until forever, and I'd be happy. But the reality is I actually think we're at a point where we have care models that have demonstrated better health outcomes, lower cost, and care models that work. And so what we as the committee felt, it's actually time to focus on those and how do they move us forward. So at each of the committee meetings, or at each of the workshops, not only do we have a patient and caretaker, we also heard from actual care models, just like we heard from City HealthWorks, how they were operating, what worked, what were their challenges, and what were their keys to success. And the second is the data on the high needs population, and then looking at the taxonomy and segmentation. So beginning to test with external audiences, if we segmented the population, does that produce value? How would you use it? What would that look like? And then in the third, and I'll present some of these results, how do you match the segmentation to the care model? And we thought that's a contribution to the field, which is we can segment this heterogeneous population into smaller, more homogeneous groups, and then if we apply care models where we know there's evidence, we think that's a contribution that will move us forward. In addition, because we were overachievers, we did convene a taxonomy and policy work groups to dive deeper into some of those issues, and I'll share with you some of our opportunities that we surfaced. So this is the book. It is here. Hopefully everyone has a copy. I think, I read a lot, but I think this is actually a quick read. We meant it to be quick and practical with an emphasis on tools, on things that you could use and say, look, we've given you a starter segmentation model. We've deconstructed some of these care models that you read about in the New England Journal on Health Affairs. We've deconstructed them into their component parts and what the preconditions that are needed. We've done the crosswalk between populations and care models, and then given you a set of opportunities for everyone to actually take action differently. So, the high needs patients are diverse and have varying needs. Jose could give us a 3-hour lecture and Ashish Jha at Harvard about how diverse this population is and how different it looks in terms of what types of services they use, and then how different it looks from year to year. If you see someone who's a high need patient in one year, they could actually regress back and be stabilized and not be high need the next, or you could be consistently high need. The three variables that we took from our colleagues at Harvard that would help us to categorize the high need patients and to segment them are first their cost. We in the health system, we spend $3 trillion, so understanding who is utilizing services and spending dollars in the healthcare system is actually very important. The intensity of utilization, so how many services are they using? And then we think this is a big contribution, and a thanks to Bruce Chernoff on this for pushing this, is the functional status. So oftentimes in the health system, we stop at the first two measures and don't add in looking at that person's functional status, which is how they live their lives every day. So getting back to Mrs. Smith, what's her lived experience? And this is a way to begin to make sure we have that in the mix. And then the other big observation, which shouldn't be news to anyone in this room, but it's important to keep on the table, is beyond folks' medical care needs, they have very significant behavioral and social service needs. And we heard that from our patient testimony. We've seen that from different data. And so part of the role of the healthcare system is to make sure that we're addressing all of the needs, not just the needs within the medical care system. So we believe, as a committee, that using a taxonomy to segment the patient could lead to better, more tailored care. So we think actually thinking about the frail elderly different than the child with a special health care need or a middle-aged adult with several chronic conditions, that you would think about a different care model for each of those populations. And so our hypothesis is that that would be a useful contribution to the field to segment this population into smaller, more homogeneous groups of individuals who have like needs. And it should be based on the care they receive, whether it's long-term care services, outpatient, hospital care, thinking through the different types of services, physical therapy, and then how often they might need it. So what we built as a group, we had a subgroup come together. So Harvard gave us the empirical information using Medicare claims data and some commercial data from Massachusetts, which you'll see in the report. A taxonomy work group kind of merged the work that was being done by the Commonwealth Fund with the findings from Harvard to come up with a taxonomy. And this is and we're calling this a starter taxonomy. I could have called it, if we were from California, could have called it version 1.0. But in our humility, we're calling this a starter kit. And we're offering this as a first cut at how do you have mutually exclusive segmentation to begin to think about how you would tailor care to these populations differently. So you can see that we came up with 6 different, based on their medical use and medical utilization, 6 different functional groups, clinical and functional groups. children with complex needs, the non-elderly disabled, persons with multiple chronic conditions, a major complex chronic conditions, the frail elderly, and advancing illness and end of life in that bucket. And what we said was that we started with a medical model, recognizing, though, that the behavioral and social considerations will come across the board for every segment of this population. And that we've folded in the functional assessment as part of this process, all of these populations, and you'll see in the care model work that doing a functional assessment of the population or of each individual is a critical piece of tailoring their care. So then we turn to care models. And one of the challenges, and we in my day job in California, we've been working on care models in the safety net population for the last 7 years. And one of the challenges has been you look at a model lock stock and it's a whole model, and you say, I'm either accepting the entire PACE model or the GRACE model or the Naylor transitions of care, but you haven't broken into its component parts. And one of the things that we as a committee wrestled with from the first phone call 2 years ago was the tension between standardization and customization. And so where do you use a standardized approach to the care of this population? And then where do you need to customize, either for community context, for individual patients? How do you balance those two things? And I think that was a point of tension in all of the workshops and in all of our deliberations. So one of the ideas, and I credit Arnie Milstein with leading us through this work, and Jerry Anderson from Johns Hopkins, was to deconstruct these models and say, look, we surveyed 14 models. I think there are many more. It's not that there might not be thousands. We took 14. If it's not in the report, please don't think it's not a good model. We were learning from this and trying to demonstrate the matching between care models and segmentation. But we determined 4 things were needed in the care models if you deconstructed them. One is the setting is incredibly important. And so if you heard about the City Health Works, I would describe that, or the Camden Coalition model, as an integrated model. It is a full service behavioral health, social health, and medical care, as opposed to a transitional model of someone's moving out of a facility. How do you make sure they have a successful transition from a nursing home or in and out of an inpatient setting? And then there are lots of models that are enhanced primary care, that are looking from the primary care setting, how do you actually do chronic home management, and how do you begin to think about that? So the first element is what's your setting, and how does the setting apply to your care model? And then here what I've shown you, and that's also, it's in the report, here what I'm showing you is the care attributes. And one could argue, looking at these are the attributes of just high quality care. We believe, though, that if you're actually doing high needs, and I'm very happy to hear that many of these same overlap with the City Health Works model. In fact, probably you could have listed all these as well. But it's important to deconstruct that any successful care model of all the ones we looked at had these elements and are standard. In addition, they have features like teamwork, coordination of care, responsiveness, a feedback loop. Again, some of the models that you heard about from the City Health Works. And then finally, and something that's probably overlooked in our field, is that culture matters a lot. And there's leadership within the organization and the technical capacity within an organization. And Diane Stewart from the Pacific Business Group on Health and her colleagues have shared their experience in California about scaling intensive primary care intervention. Could talk a lot about the relevance of culture. So what we did was deconstruct these models and then aligned 14 of the models that we heard from. And again, if you don't see this, it is not a statement that we don't think it's a great model. What we are trying to do here is say, is there a match between a type of care or a care model and a specific population? And the answer is, we actually have care models that work for the segments that were done. So it shouldn't be an excuse that we don't have any evidence-based or promising care models for the different segments of the population. And those with an asterisk have actually explicitly included social services and behavioral health in their model as well. So what this chart tells you is that it really does, different care models actually work or are tailored to different populations. And that is something we think could be a contribution moving forward if we began to think about whether a health system or a plan or even a Medicaid agency segmenting your population and then thinking about which care models work for that, thinking about what the attributes are. We believe you're going to get better care and better value. I mean, that's the hypothesis that we want the world to test. So that was the good news. The challenging news is our policy environment is not super conducive to merrily taking us along this path. I think Jamila could talk to us about that, and you heard that mostly she's foundation funded, but any of our care models would tell you they feel more like salmon on a given day swimming upstream, and that our policy environment is actually, current policy environment is not conducive to making this the standard or norm of care. And we start, and I think the committee started with, and each of the workshops started with the most important, which is the financial mismatch. Financial incentives between the services that are needed for high needs patients. Both the fee-for-service component of our system of paying for each service. The question, particularly in the Bipartisan Policy Center, did a lot of work around this and has issued reports last year on the combining Medicare and Medicaid funding streams for those dually eligible individuals, and how do we actually blend those funding streams and give flexibility to provide the type of services that people need. And I think it's a strong opportunity from the committee is the value-based payment models that integrate social services and behavioral health would actually facilitate a lot of this work and accelerate much of this work. So if we had a value-based or value-oriented payment model that paid for behavioral health or allowed behavioral health and social services, that would be a large step forward. And the health system is very fragmented, even in the best of circumstances where people are wanting to do the right thing. We have big fragmentation just within healthcare and medical care, and then if you extend that to behavioral health or social services, you have whole different systems with their own funding streams, their own outcome measures, their own imperatives, and it becomes very different. There's a level of fragmentation separate from our policy, maybe due to our policy and funding framework, but it's a separate phenomenon that we observed. And then I think I'm glad that you raised the workforce and training issues, and we wholeheartedly agree about training and certification opportunities, and particularly for non-traditional health workers, that there is a lot of work to do around training of folks to understand high needs and that level of coordination that needs to happen. And then finally, data. Seems kind of wonky and maybe second tier, but the power of Harvard being able to look at the actual, what services people actually use for high needs patients and that they change year to year, having that data, for programmatic feedback loops, but also to inform public policy of what is the population, what services are they using, and then are we actually seeing results? Are we seeing things change based on the interventions that we're doing? And so there are challenges clearly in the data, particularly when you add in services outside of healthcare, but we think that's a fundamental building block if we're going to do this at scale and make these models the norm, shifting the norm rather than making them the exception. And that we have opportunities galore. I counted, we have 36 in the full report, so please, I'm giving you the top 6 here. And the other thing I would say to you is we are very clear that there are opportunities at all levels for all actors. So this is not one where it is let's sit back and wait for federal or state governments to fix things, or this is not a health plan issue or a systems issue or a provider or not a patient issue. This is an all play. So that in order to make this work, we actually need changes across the board in terms of how we think about high needs patients. First is refining the taxonomy. You'll see in the book Denver Health shared their model. We believe there are others, and Optum actually as well. Optum Labs presented some of this work. We'd love to see people take this model and refine it and put it in real world settings and figure out, okay, this worked, this didn't work. We'd actually want more granular here, or here's how you'd incorporate it. So again, that's why we're calling it a starter. We think people, and with better and different data, could actually come up with their own versions of the segmentation. And what we would ask is that you share them and that you put them out to the field. And if we really want to make this the standard of care, we actually need to share what we're doing that works and share what doesn't work. This integration of delivery system, I was pleasantly saw that the National Quality Forum this week approved some new measures on behavioral health and on coordination of care. So this is an issue that is gaining traction in the world. We think there's more work to do on what that looks like and how do you actually do the nuts and bolts of integration and coordination, particularly outside of healthcare. Spreading and scaling issues, I think, foil all of us, even the best intention on the supply side. So how do we share what learned? What were the key elements that actually worked? Why is local context important? How would you adapt it? What elements are standard versus what you customize? I think that work, there's a tremendous amount of work that could be done by health systems, health plans, providers as well. This one is an incredibly strong one, and I think 100% support from the committee as to new payment reform models and incentivize the adoption of these models and the integration of care. The Center for Medicaid and Medicare Innovations has done some of this work, and Rahul came and spoke to us. We think that should continue apace and accelerate, if anything, that you actually have the funding models, so you don't need extra support. You actually have the funding models that support this care as a regular course of business. And we do need to get serious about measurement. So several years ago, we had the vital signs report with the domain, 15 domains. Our current measurement system with 1,300 measures coming out of CMS, 600 out of National Quality Forum, all mostly measuring process, doesn't do any favors for a high needs population. Thinking about true return on investment measures that are omnibus, where we could begin to think about, are we getting value, and more importantly, are they getting value from the system? And I think that's work. There was definitely interest in our last workshop with researchers and National Quality Forum and others to take this work around measurement forward and to think about, do we have more holistic measures, particularly for these high need populations? And then finally, to create roadmaps of how do you move this forward. So working with these leading pioneer organizations, what would their roadmap look like to take City Health Works or any of these models that we've shown effective, and how would you take that into other settings? And I want to close with a quote that's in the report that says, from Mary Ann Sterling, that says, "I think what we are doing is culture change on a grand scale, probably on a scale that has never been done before in this country. I think we all need to encourage our peers that it's going to take some patience and perhaps one or two do-overs, a left or a right turn along the way, but it is definitely doable." So we're left with the message to everyone that while this is incredibly hard work, this is the imperative of our health system. How we take care of our most vulnerable neighbors is the reflection on us as a society. And what our takeaway from all the work in the last 2 years, all of the consultation and input, is that we actually have models. We know much more than we think. It is now up to us to do, and then to do again, and then to learn from that doing and to continue on this process. And that will be the only way, in some sense, that we'll make progress, is to continue for all of the actors, from federal policymakers all the way down to patients and families, to take a different approach to solve this issue. So we look forward. We think, as Mark Smith, my colleague from the California Healthcare Foundation, would say, we believe this is the end of the beginning, and this is actually where the real work happens, and we hope acceleration of the pace of change. And so I'm really looking forward to the reaction, because we've put this forward as our best thinking, and what we're really looking forward to is how folks in the world respond to it and say, we'd like to take it. This would take those right and left turns on our progress to a better health system. Thank you. All right, any questions? Do we have time for a question? Or, sorry, the additions that hopefully I characterized it pretty well for the committee members. And I would encourage you to read the text.
This is Dr. Poplin again. I didn't see anything about community involvement. Communities are going to be very different from East Harlem to rural Louisiana, rural Mississippi. You need patient involvement, and not just people who do it all the time, but some way to include, because this is a community service at base, not something delivered from on high or the same everywhere. So what have you thought about that?
Sure, thank you. And that just wasn't in the slides, it's in the report. So a couple of things in the cultural context, and the place where we believe there should be customization is community context, one of those places. And then it's a great question to clarify. When we were looking at the key social determinants, one is social isolation Another is community deprivation, housing insecurity, and socioeconomic status. So we also believe that that social context is incredibly important to understand. Are folks getting, kind of negatively being impacted in their community while the health system is trying to fix something, and should we be doing it? And then we firmly believe that in the culture section, as I said, I just showed one, I showed the attribute slide on the medical care, but in the cultural section, community priorities, community context is essential if these models are going to go from Camden to even to Trenton, much less to San Jose, California. Community context matters a lot in terms of that. And so we do have a chapter, I just didn't put it in our slides today, but we're very aware and think that's a critical piece. And we do think I think as committee could correct me, but that's where we come down on the customization part. That's not the place where you standardize. We're not trying to homogenize communities and make them all feel the same. The standardization comes in some of the more generic care practice. Any other?
Hi. First of all, congratulations. This is a Herculean effort with an incredibly fantastic outcome. But I don't mean to bring up perhaps difficult memories, but could you share with us some of the biggest points of debate that came up when you were trying to, wrestle with these really complicated issues?
Sure. I'd say the first, and I think it is still a point, is there enough evidence to move forward, or should we ask for better evidence before we would say that we can move forward? I think that's and particularly we have a mixture of government folks, practitioners, and academics. I think it was a tension of my committee members would nod that how much evidence is enough? What does it look like when we say we want to spread or scale these endeavors? What is that, and what does it mean? I think we came up with a compromise, which is the attributes of where there has been where there have been promising results and there has been evidence, and deconstructing those elements. I'd say that was one that was a big issue. And then the segmentation of at what level, how do you use it, where do you use it, who's going to actually use that work for segmentation in terms of that was a big piece. I'm trying to think of what other, then the standardization, customization, covered everyone, which is where should we say to folks, this should be a standard of care, and there shouldn't be a huge amount we shouldn't have everyone building 31 flavors of team-based care. That we should, you can decide who's on it, but we're not going to redefine team-based care or some of that. I would say those would be the biggest, which is, are we far enough along to make recommendations? How are we going to use the segmentation? Who's going to use it at what level? And then, frankly, and I think with our colleagues at Harvard, anyone who's inside a system should have dramatically different and better information than our segmentation model. And so we put out a segmentation model using claims data and using some other kind of modified Delphi method. If you're inside a health system, if you're at a health plan, you actually have access to a lot different data, so you may come up with a different segmentation. So I think we struggled with how do we put this as representational without telling folks, you have to do it this way. And we gave the example of Denver Health, which is a very different cascading model than we did here. And so that's, again, why we, trying to figure out how can we be helpful without seeming that we're out of touch because someone's going to use a different data set and get very different answers. Does anyone have other? Is that one more question? Okay.
Hi, I'm Joanne Lynn from Altarum Institute Center for Elder Care and Advanced Illness. The methods we use, this is obviously terrific, and I'm really glad you pulled it all together. The methods that we use always constrain what we can see. Right. And so if we start from what is proven in the evidence base at present, one of the striking constraints is we are constrained by our laws, regulations, and so forth that keep some things from being tried. And therefore we have no evidence as to how well they would work. And the one that I think is most striking was actually foreshadowed by a couple of the other questions, which was, don't we think that we might do somewhat better, at least on some of these categories, if we allowed geographic communities to organize care, at least some of the care, some of the time? At the present time, we only allow providers and insurers to parse up the population. We don't allow Santa Clara to do Santa Clara,
Right.
or Chicago to do Chicago, or Washington, D.C. to do Washington. Not even to collect data that would be relevant. And yet every other country manages, especially this population, on a geographic basis. When I was head of cancer and chronic disease here in the city, we had 60 home care agencies. And we did a calculation of how much we were wasting to maintain the illusion that they were somehow creating quality and efficiency. And it turned out that half of every dollar spent on home care was spent to maintain the illusion that having 60 home care agencies somehow made it wonderful.
Course, right.
So I'm just calling on us to celebrate this and work as far as we can with what you've done, but to keep worrying about where we were not allowed to go in our current regulations and structures, because I think that one of the big things that would really work is geographic.
And I'd say you've named the last another tension that we had as a group, and we do acknowledge in the report that we use the medical model to start, despite its limitations that you raise. I think there was some discussion in the group of should we flip the segmentation over, and it's really about social, it's starting with social and community health. And so we chose this as a starting point. So it's an interesting, I think you raise an interesting tension, which is to be relevant in the current model, you have to have some anchor that someone will recognize. And yet, from my last quote and from the challenge, we were also trying to be bold and transformative. And I think that's, I'd love to hear the reactor panel respond to that. And I think you make a very good point. We did end with the decision of noting that that was a limiting factor and yet choosing it. And so I think that's, it's a good point. Well taken. Thank you.